So today we're going to be discussing the skin, head, eyes, ears, nose, and throat exam. I've already washed my hands and greeted my patient. And so I'm going to start by inspecting the skin. I'm going to look at the skin of the face and neck as well as the arms. I'm looking for any pallor, any rashes, any other significant findings. Next, I'm going to start at the top of the head, and I will start by inspecting the head for any deformities, masses, anything like that. Next, I will palpate the head. Again, I'm feeling for any deformities, tenderness, any depressions. Next, we'll move on to the examination of the ears, and we'll start with the external exam. I'm going to start by inspecting the ears. My patient today has earrings on, and they don't seem to be interfering with my view or examination of the ear, but if they are, you can kindly ask your patient to remove them. Do not remove them for them. So again, I'm just inspecting the ear, including the auricle, the tragus, and the lobe, and I'll do the same thing on the other side. Okay. Next, I will palpate the ear, the external ear. Again, just looking at the auricle, the lobe, and the tragus, and we'll push slightly on the tragus to see if there's any tenderness. We'll look into the ear, and to do this we need our otoscope. So we'll take our otoscope and the smallest speculum that we have, and you simply twist the speculum onto the otoscope so that it is secure and it doesn't fall out while it's placed in the patient's ear. In order to examine the external auditory canal, you will need to pull up, out, and back on the auricle, and then gently insert the otoscope into the external auditory canal. Now, if you notice, not only am I securing the cord with one hand, the hand that I'm using to pull up, out, and back on the ear, but I'm holding the otoscope itself like a pencil and then using an additional finger to brace it against the patient's head. The purpose of this is to give you more control over the otoscope so that you aren't jabbing it in, or if the patient moves, you don't injure their ear. If you're having trouble seeing in the external auditory canal, you can ask the patient to turn their head just a little bit that way, and that way you don't have to bend over so far to see down the canal. So right now I'm examining the external auditory canal, looking for any lesions, bleeding, erythema, and I'm examining the tympanic membrane right now, looking at the structures involved in that. I'm going to come across the patient and do the same thing on the other side. Examine the patient's left ear, again pulling up, out, and back on the auricle and inserting the speculum into the external auditory canal. We're using our a spare finger to brace against the patient's head, so that we do, in fact, have control of the otoscope at all times. We're examining the external auditory canal, and then looking at the tympanic membrane, again, picking out all our structures and looking for any abnormalities. We will then slowly remove the otoscope, take the speculum off that will then be discarded, and replacing the otoscope. After we've inspected the tympanic membranes and the external auditory canal, I'm going to check for auditory acuity And there are several ways that you can do this. If I ask the patient to cover one ear, if you could please do that with your left hand. I'm going to whisper into the uncovered ear and ask the patient to repeat it back to me.
99.
Alternatively, with the other ear still covered, you can rub your fingers together in the uncovered ear and ask the patient if they can hear that.
Yes, I can hear that.
Okay. Please switch hands and cover your right ear, and we'll do the same thing on the other side.
Yes.
The next part of the ear exam is to check the Weber and Rene tests. The Weber test checks for lateralization of sounds. For this portion of the test, you will need a 512 hertz tuning fork. We simply strike the fork, we'll put it on the crown of the head, and ask the patient to describe if the sound is heard better on one side or the other, or if it's the same in both ears. You don't necessarily need to strike the tuning fork. You can usually merely make the sound by squeezing the ends squeezing the ends together and releasing. On top of your head, and I'd like for you to tell me whether you hear it better in one ear or the other, or if it's the same in both ears.
Okay. It sounds the same in both ears.
Okay. Thank you. The next test is called the Rene test. And for this exam, you will again strike the tuning fork, place it on the mastoid process behind the ear, one ear of your patient. You will ask the patient to let you know when they can no longer hear the sound. When they tell you that, you will remove the tuning fork from the mastoid process and place it in front of the ear. And again, you will ask the patient if they can hear the sound, the tuning fork. So we're going to start, and we'll do this with the patient's right ear first. Okay. So if you look straight ahead. So I'm going to strike the tuning fork, place it on the mastoid process. I want you to tell me when you, can you hear that?
Yes, I can hear that.
Tell me when you can't hear it anymore.
Okay, I can't hear it anymore.
Can you hear that?
Yes, I can hear that.
Okay. We would do the same thing on the other side. This test is checking for air conduction versus bone conduction. After finishing with the ear exam, we're going to move to the nose. And first I'm going to start by inspecting the nose, looking for any asymmetry, masses, deviation, and I don't see any at this point. Next I'm going to check for nasal patency, and so I'd like for you to cover one nostril and breathe in and out through the other nostril. Good. And now check the other nostril. Wonderful. And I can hear that the patient is able to breathe adequately through both nostrils. We will again use our otoscope to examine the inside of the nose. So taking our otoscope, we will choose the largest speculum available. Again, make sure that you aren't using the same speculum that was used to examine the ears. For this exam, we need the patient, we'll ask the patient to bend their head back or flex their neck so that they're looking upwards. Then we will put our finger on the bridge of the nose to widen the nostrils and slowly insert the speculum into the nares. So, can you please look up for me? I'm going to go ahead and look into the nostril. If you can look towards me and then bend your head back. I'm then going to lightly push up on the tip of the nose, and the speculum will be inserted into the nostril before you look through the viewfinder. Before you look through the viewfinder. We'll look look through the viewfinder and we'll see, we'll isolate the turbinates as well as the nasal mucosa. We're looking for any bleeding, masses, polyps. We'll check the other nostril this time, again pushing up slightly on the tip of the nose, inserting the speculum into the nostril before looking through the viewfinder, and then looking through the viewfinder to check out the mucosa. The next portion of the exam will test for sinus tenderness. And so for this exam, you come to the front of the patient, and I'm going to put my thumbs on the patient's maxillary sinuses. So we'll press against the maxillary sinuses, asking the patient if there's any tenderness at all.
No, there's no tenderness.
Okay. And then we'll do the same thing against the frontal sinuses.
No, that feels fine.
Okay. Next, we're going to move to the mouth, and for this portion of the exam, it is required for you to have gloved hands. So place your gloves on, and we're going to start by examining the lips. We're looking for any discoloration, deformities, ulcerations. This is a common place for skin cancers to start. So we want to make sure that we're examining for any asymmetry or masses. Next, we will examine the inside of the mouth, and it's best to do this with a light source and either your finger or a tongue depressor. The tongue depressor it is key to make sure that you're not using a finger that is in the mouth or manipulating the mouth that has then touched some of the tools that you'll use. So this will be my safe hand to use, as it hasn't touched anything yet. Okay. Now, I'd like you to go ahead and open your mouth. And I'm going to use a light source, either a pen light or your otoscope, and we'll look at the oral mucosa. We're looking at the buccal mucosa, the tongue, the posterior oropharynx. To accomplish this, we will also gently push down on the tongue, and we can see the uvula, the palatine tonsils, the posterior and anterior columns, and all the way to the posterior oropharynx. Looking at the buccal mucosa, we're looking for any ulcers or abnormalities. We're also examining the teeth to make sure that there are no missing teeth or decayed teeth. We can use our tongue depressor to examine the entire mucosa. Last structures that we're looking for are the salivary duct openings. And you can look for the submandibular and the parotid duct openings. The parotid duct openings are along the buccal mucosa, and the submandibular openings, duct openings, are on the floor of the mouth. Again, using my clean hand, we're going to palpate the tongue. So I'm going to have the patient open her mouth again and stick her tongue out. And I'm gently going to feel for any masses or induration. We're looking for any sores. We can move the tongue over to the side and look along the lateral portions of the tongue. And again, looking for any lesions. Next, we'll palpate the floor of the mouth. So again, open your mouth and lift your tongue. And we're palpating the floor of the mouth, feeling for any tenderness, masses, and any ulceration. I've removed my gloves, and we'll move on to palpation of the lymph nodes. Lymph nodes are normally very small and difficult to feel. On a patient without any disease, in most cases, you will not feel the lymph nodes. But it's important that you know where to check for enlarged lymph nodes, as well as noting the drainage patterns of the lymphatics, so you know if you do find an enlarged lymph node, where the disease process might be. So we're going to start off by palpating several lymph node groups. And we'll start off with the preauricular. the postauricular, the occipital, the tonsillar, the submandibular, the submental. You'll next check for the superficial cervical chain, which runs right over the sternocleidomastoid muscle. You can also check for the deep cervical chain, which runs right beneath the sternocleidomastoid. The posterior cervical chain, which runs right anterior to the trapezius. And the supraclavicular, which lies right superior to the clavicular. I did not palpate any enlarged lymph nodes. If you do palpate a lymph node, it's important to make note of whether it is tender, hard, the size of it, non-tender, or fluctuant. To examine the thyroid, we need the patient to have a cup of water, and we're going to ask her to swallow it as we're doing portions of the exam. It's best to start by inspecting the thyroid. It's on the lower portion of the neck, and so you want to look straight on to your patient. You can use a pen light for some tangential lighting. And we're looking for asymmetry or enlargement of the thyroid itself. The thyroid can be palpated either from in front of the patient or from behind the patient, and frequently feeling from behind the patient is easier. So I'm going to come directly behind the patient. I'm going to find my landmarks. So my cricoid and thyroid cartilage. Inferior to that is where the isthmus of the thyroid runs. You usually cannot palpate the thyroid, or the isthmus of the thyroid, but if you move laterally on either side of the trachea, you should be able to palpate the organ. And so I believe that I have the thyroid isolated here. I'm going to ask the patient to take a small sip of water. And you should feel the thyroid, the organ, move up and down with the swallowing mechanism. Take one other sip of water. And now that I've found both lobes of the thyroid, I'm going to come again and see if I can feel for the isthmus, which again I'm having trouble feeling. So that ends the head, ears, nose, and throat exam. We'll discuss the eye exam separately.